Good afternoon, everyone. I welcome you all to this webinar. Today we'll be discussing about the multidisciplinary management of esophageal cancer. So we have a few cases shortlisted in which we will be discussing mainly two cases, considering the time that we have with us. And then we will, if time permits, we will go for discussing other cases as well. So to start with, I'll share my screen. So I welcome all the experts, Dr. Kumar Prabhash, Dr. Anil Tibdewal, and Dr. Devyani Nyogi. And it is our honor to have them on this webinar today. Welcome, sir, and welcome, ma'am. So about Navya, Navya is a cancer informatics and patient services company that leverages technology to provide personalized evidence-based cancer treatment plan. We also work with the state governments to provide service to the underprivileged patients. Currently, we are working with the ACCF Foundation, the Assam Cancer Care Foundation, and this webinar is in association with them. Kumar Prabhash, who is the head of medical oncology department at TMH. He has more than 20 years of experience, and he is a known person. There are no words to describe his expertise. Sir, I welcome you to this webinar and request you to say a few words.
Yes. Hi, I'm Dr. Kumar Prabhash. I'm a medical oncologist and I work at Tata Hospital. And thank you for inviting me for this interaction today.
I welcome Dr. Anil Tibdewal, who is the Associate Professor of Department of Radiation Oncology, TMH Mumbai. Again, he has more than 10 plus years of experience in radiation oncology. Areas of expertise are thoracic and esophageal cancers. He has various publications in journals and he has presented in a lot of national and international conferences. They are one of the key opinion leaders in radiation oncology. I welcome Dr. Anil Tibdewal. Sir, I request you to say a few words about yourself.
Yeah, hi. Hello, my name is Dr. Anil Tibdewal. I'm a radiation oncologist and I do practice lung and esophageal malignancy. I'm looking forward to the discussion of those 2 or 3 cases that we are going to discuss in the next 1 hour.
Thank you, sir.
Thank you.
So I welcome Dr. Devyani Nyogi, Associate Professor Thoracic Surgery, Department of Surgical Oncology, TMH Mumbai. She is trained from KM Mumbai and on surgical oncology from TMH Mumbai. She has more than 10 years of experience in surgical oncology. She has specialized in lung, esophageal, and mediastinal surgery. And her areas of interest are minimal, invasive, and robotic surgeries. She has various publications and she is a member of various associations. I welcome you, ma'am, and I request you to say a few words about yourself.
Thank you. Thank you very much for having me here. And my name is Devyani Nyogi. I am currently on the team of thoracic surgery at Tata Hospital in Mumbai. And all three of us work closely together. And we hope that the cases that we discussed today serve the purpose of clarifying the treatment protocols for CA esophagus. And I look forward to starting the session.
Thank you, ma'am. So we will have 2 case presentations. The idea is that we will present the case, which will be form the basis for the expert panel to discuss and debate and give their expert insights on the cases and how to manage. Because it's a very vast subject, we have gone with few selected cases so that there will be some points where they can give more guidance and advice on the case management. And after each case presentation, we will have a short question answer session. And then in the end, we will have one more session and then we will wrap it up with a few points on the recent advances and the take-home message from the panel of experts. And I request all the participants to be on mute during the entire session. And if you have any queries, you can please put that in the chat so that the expert can address those queries during the discussion itself. So with this short introduction, I would request Ms. Apurva to start the presentation of the first case.
Thank you, Dr. Naga. I welcome all our esteemed panel members. I'll start with the presentation of case 1. We'll start with a locally advanced esophageal cancer case. It's a 62-year-old male. The presentation starts with the complaints of dysphagia and hematemesis. This was in June 2023. The FTG PET-CT dated July 8th to 2023 showed a 8.5 into 0.9 centimeter esophageal thickening extending from D2 to D6 to D7 junction. There were small bilateral proximal periesophageal lymph nodes along tracheoesophageal groove, the largest of which measured 1 centimeter. The SUV marked was 2.93. There were few sub-centimeter left gastric lymph nodes, largest of which measured 0.8 centimeter. There was no evidence of malignancy noted elsewhere. This was marked as low-grade metabolically active small bilateral proximal periesophageal nodes along tracheoesophageal groove and non-FTG with few sub-centimeter sized left gastric nodes suspicious for being metastatic. There was a gastroscopy done which came out to be suspicious for esophageal cancer, and the biopsy done from the same site confirmed squamous cell carcinoma with very focal invasion. The staging was found to be T1 question mark, N2 question mark, M0, which is stage 3. The patient was started on neoadjuvant concurrent chemoradiation therapy with carboplatin and paclitaxel. And 23 fractions of radiation therapy were completed and a response assessment scan was suggested. There was a jejunostomy which was done in between, due to which one cycle of chemotherapy was missed. This was followed by a response assessment CT chest abdomen scan, which showed a 12.9 to 1.03 thoracic esophageal segmental wall thickening, again extension from D2 to D8 vertebral levels. This showed a possibility of post-radiotherapy changes. However, presence of underlying malignancy or neoplastic etiology cannot be ruled out. There were multiple sub-centimeter periesophageal lymph nodes, largest of which measured now as 1.0 into 0.84 centimeter, D2 vertebral level lymph node. There were other few sub-centimeter pre-paratracheal and subcarinal region lymph nodes. And there was a stomach fundus body wall thickening, which was possibly changes of gastritis. There was an endoscopy done, which again showed post-radiation therapy changes and a nodular lesion in mid-esophagus, which was termed as question mark residual disease or duodenal submucosal lesion or a lipoma. An endoscopic guided biopsy was again done from the esophagus, which came out to be no evidence of malignancy. The general condition of the patient was limited and with the ECOG score of 2. Patient was on external food pipe, and the caregiver wanted to know the role of surgery. If surgery is not considered, they wanted to know an alternate treatment, and if concurrent chemoradiation therapy should be considered again. I'll pass the discussion over to the panel members.
Sir, Dr. Kumar, Professor, I think you can start here.
So, in general, overall treatment, what was planned is what we routinely do, that in this setting, you give chemotherapy plus radiotherapy. But another question was, if I understood correctly, 23 fractions were radiotherapy given in how many? 23 fractions were given. How much was the total dose? What was the per dose fraction?
The total
Sir, I get
dose was
41.4 grain 23 fraction that we usually follow the cross protocol.
Okay, so that was again optimal dose of treatment which was given. Good thing for patient has been that the response has been good. Endoscopy wise, disease we are not able to see that there is a residual disease, and that's why the question has come up what to do next. Otherwise, usually in this setting, you give this treatment and subsequently we do go ahead with surgery. And in general, today also my recommendation will remain that, or my thought process will remain that surgical intervention will be important, and it's better that we do the surgery. And if we thought of not doing surgery, then maybe radiotherapy dose could have been far more, which could have made that discussion more meaningful. But with this dose of radiotherapy, it will be better that we include surgery in the armamentarium of treatment for these patients. We can talk about if we take surgery or not, and then what to do subsequently.
Okay, sir. Dr. Devyani, up to you now.
Yeah, so as Dr. Kumar Prabhash said that, the de facto next step in this kind of a case would be to go ahead with an esophagectomy. There are a couple of concerns, however, in this particular case that you have shown. The first one is the ECOG status of the patient has been mentioned as 2, which concerns me a little bit because esophageal surgery is a very demanding procedure physiologically for even an absolutely fit patient. So that ECOG 2 status concerns me a little bit, and I would want to dig into that further to know why the patient is PS2. The second thing, also the CT scan report, which has been put up in this note, says that the planes with the carina and the bronchus are query. They are not very well defined planes. So even that is a second thing that concerns me a little bit. What I would like to do in this circumstance is to dig into the performance status of the patient a little better. See, is it because of nutritional reasons or anything else that can be optimized to improve the general condition? And I would also want to do a fiber optic bronchoscopy to know what the planes with the trachea and carina are like before I plan surgery for this patient. If the general condition improves by our nutritional intervention, and if the bronchoscopy is clear, then yes, I agree surgery would be the way to go in this case. But if either of the two are a problem, then I think I would again take the opinion of Dr. Kumar Prabhash and bring in Dr. Anil also to know if anything more can be done, because the radiotherapy dose given right now is the cross protocol, which is by itself not a curative dose. So technically this patient needs surgery, but if it's not possible, then other options will need to be considered.
Yeah, so I agree with Dr. Kumar Prabhash and Dr. Devyani, because what we usually follow and the standard treatment across the world for squamous cell carcinoma is neoadjuvant chemoradiation therapy followed by surgery. As Dr. Devyani has pointed out, the performance status was 2, and I also read that the patient had a severe esophagitis. So we have a concern about severe esophagitis as well as performance status 2. The other point that I want to highlight is that the patient completed the chemoradiation therapy in the month of the July or August somewhere. So it has been now 4 months, and we have done a CT scan maybe after 6 to 8 weeks from the date of completion, and it has shown that there is a partial response and an endoscopy also suggestive of a good response to the treatment. So usually we do the surgery from 4 to 6 weeks from the date of completion, and 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 as Dr. Devani has said that the surgery is slightly demanding, especially in patient with a performance status of 2, and those in patient who had a severe esophagitis. We usually don't see a severe esophagitis with a dose of 41.4. So these all 3 points needs to be keep in mind. However, we do get such patients who do not want or may end up in not having surgery or have missed the bus for the surgery, especially the window of 4 to 8 weeks of the timeline post radiation therapy. So this patient has already had been 12 to 16 weeks post the treatment completion. So given the fact that he has already passed the window of the bus, passed the window of 8 to 12 weeks, what we would suggest is that to repeat a scan to assess the current status of the patient as of now, and if the disease is continuing to show in a remission state after the new urgent CTRT, we would like to have a repeat UGI and a biopsy, basically to look out for the residual lesion. If the disease is showing a residual lesion, I would request my thoracic surgery colleague to go in and do the surgery after proper nutritional rehabilitation and improvement of the performance status score. If the surgery is not feasible, and if the disease is showing any signs of any recurrence, then there is a dilemma whether to offer more chemotherapy or more radiation therapy. I would go towards Dr. Kumar Prabha sir, because we have already delivered 42 gray more or less, and the chance to have curative doses of radiation therapy will be limited. So that would be my opinion. I would like to just go back to Dr. Devyani and Dr. Kumar Prabhash if they want to add anything. Otherwise, I think more or less that is the situation.
Yeah, Anil, I think perfectly summarized. But again, for the benefit of the audience that we have, all three of us would like to reiterate that with a 41.4 gray dose of radiation, this is a neoadjuvant dose.
Yeah,
And
neoadjuvant.
ideally, this patient needs
Should,
surgery.
yes.
So
Obviously.
what Dr. Anil said about waiting and watching is only if surgery is not an option, given the general condition of the patient or due to obscured fat planes with the airway. That is an option we have. But if those two factors were not there, then surgery would have been the plan for this patient.
Yeah, agree.
So the patient could have been better managed if we had started with surgery.
No, neoadjuvant chemoradiation therapy. So
Okay.
repeat a PET-CT scan after 4 to 6 weeks. So repeat a UGI-scopy depending upon whether thoracic surgery would like to have the repeat UGI-scopy or not. And obviously, surgery is the completion treatment that you do in an resectable squamous cell carcinoma of the esophagus.
So the treatment so far is correct, Dr. Naga, but I think we missed the bus with the timing a little bit, because surgery would have been the right way to go about within 4 to 6 weeks, like maybe 6 weeks after completion of radiation, and not waited for 4 months.
Dr. Kumar Prabhash, any role of chemotherapy or medical oncology or any other modalities in this kind of situation here? If you can just let us know. After the surgery and radiation. Sir, you are on mute.
Yeah, if Kumar sir is not available, I would like to ask Dr. Devyani that, say for example, if the recent PET-CT scan and the UGI scopy still shows no evidence of disease, how much benefit we will have in doing the completion esophageal surgery at a gap interval of 4 months? Just for the benefit of the audience and for the discussion.
Yes, and I think we
Dr.
have
Kumar
we have seen such cases in the past. And what I would say is completely your point is well taken. The best outcome for this patient would be getting his surgery within 6 to 8 weeks of completion of neoadjuvant treatment. Now, if I put into context the age of the patient, which is not too bad actually, but the performance status and the fact that there are query planes with the airway, and the fact that we've already lost 4 months after completing neoadjuvant therapy, the current PET-CT shows no uptake, and the upper GI shows minimal disease, no lesion per se. The biopsy has come negative. In such a circumstance, I would not mind keeping this patient under close observation, as you had suggested the first time, especially because we've lost the golden window. Dr. Kumar, your take on this?
Oh, sorry. I think I missed that part. So I agree with both of you. And this is what the clinical judgment is about when we are in the clinic. Data is one part of it, but all the data helps us in deciding that if you have a patient and patient is there for last around almost now 4 months or we take it as a complete remission. Endoscopy showing nothing much, scan looks like we are hoping that if the response is good here, the node has responded very well and there is no disease there, and I won't mind having some close follow-up with some scan in between to reassure me that the complete response remains maintained, and if there is some inflammation that settles down. And if that is the case, yes, this one option of observing patient is not a bad option in this setting, and maybe clinically in these circumstances maybe the appropriate option. As much I again reiterate, which was mentioned by both my colleagues, that in today's time, if you are giving around 41 gray of radiotherapy with chemotherapy include your surgeon as early as possible. They should be part of the decision making.
Thank you, sir. We will move on to the next case, and I request all the experts to please stop us or pause the presentation in between if you find that there is a new additional information that you can give us on better management of the case, so that we will have the ongoing discussion while the presentation is on, instead of waiting till the end. Thank you. Mr. Apurva, please present the next case.
So I'll present a case which is locally advanced esophageal cancer versus metastatic esophageal cancer. This is a 77-year-old female whose presentation starts with dysphagia, anorexia, cough and weight loss in November 2023. She initially had a spinal compression fracture in May 2023 and had symptomatic treatment for the same. CT chest done in November 5th, 2023 showed a 5 centimeter into 1.3 centimeter mid-esophageal wall thickening with fat stranding. Multiple left supraclavicular along with paratracheal, pre-aortic, precarinal, subcarinal lymph node, largest of which measured 3 into 2.0 centimeter in left supraclavicular lymph node. Lung, right upper lobe, right middle lobe, bilateral lower lobe, subpleural fibrotic opacities were noted. Additionally, small right middle lobe lung, ground glass opacities were noted. D12 vertebral body, severe compression or burst fracture was noted. This was inferred as mid-esophageal wall thickening, and lung fibrotic opacities were sequel to an old infection. There were multiple mediastinal lymph node noted. Esophagogastroduodenoscopy done showed esophagus at 25 centimeter, exudative pus with ulceroproliferative growth. This was extending from 26 centimeter to 30 centimeter. And a scope was negotiable across with mild resistance. There was an endoscopic biopsy done from esophagus, which confirmed squamous cell carcinoma. Grade of cancer was 3. A subsequent FDG PET-CT showed a 5.5 into 1.7 centimeter, 30.1 with luminal narrowing. There was abutment of trachea, carina, bilateral proximal bronchi, effacement of fat planes with arch of aorta and descending aorta less than 90 degrees. There were few sub-centimeter bilateral level 1 to 3 lymph node with an SUV of 12.7. There were a right level 6B, left supraclavicular, paratracheal, subcarinal, retrocural, paraesophageal lymph node, largest of which was 3.6 into 2.3 centimeter left supraclavicular lymph node with an SUV of 11.9. There were gastric lymph nodes, left gastric LN 0.6 centimeter with an SUV of 1. Is there a doubt over here? T12 vertebra collapse, FTG evit, which is non-specific uptake. Involvement of posterior elements with extraosseous paravertebral soft tissue thickening was noted. This was inferred as likely carcinoma of esophagus. Right level 6B lymph nodes, supraclavicular lymph nodes, paratracheal, subcarinal, retrocural, and paraesophageal lymph node were termed as metastatic. Collapse of T12 was most likely benign, osteoporotic fracture than metastasis. Prominent gastrohepatic and left gastric lymph node were concerning for metastasis. Diffuse osteopenia, bibasilar atelectasis, liver fatty infiltration was noted. MTB was not detected, anti-HCV positive. Clinical TNM stage was stage 4A, M1 because of above involvements. The stage 4A was given by the hospital and stage 4B was termed by us based on the above involvements in the radiologies. Post which patient was started on first-line carboplatin paclitaxel, which is still ongoing. 2 cycles of chemotherapy was administered and the last was administered on December 9th, 2023. They were also started on denosumab for bone mets. PD-L1 positive, 10%. General condition is 1 to 2. And patient requires mild to moderate assistance due to osteoporosis. Patient is planned for paclitaxel, carboplatin, pembrolizumab, supposed to be started on December 16th, 2023. I'll pass on the discussion to the members.
Dr. Anil Deval, I think we can start from you.
I would just like to know about the grade of dysphagia. So say, for example, if the patient is able to swallow semi-solid as well as solid, we would not usually offer the palliative radiation therapy. I would like to have Dr. Kumar Prabhas's opinion for the role of chemoimmunotherapy. However, if the patient is having a significant dysphagia, even to the liquids, then first one is the nasogastric tube insertion or a PEG insertion. So depending on the choice of the patient, as well as we can offer the palliative radiation therapy for the symptomatic relief of dysphagia, and then can go ahead with the systemic chemotherapy or the systemic chemoimmunotherapy option. So what was the grade of dysphagia for this particular patient?
I think we do not have that information available, sir.
Okay. So if the patient is not having very symptomatic dysphagia, then I think Dr. Kumar sir will give the opinion for the chemotherapy or the systemic therapy. Sir, over to you.
Someone rightly pointed out in the chat box regarding HCV positivity, and that is important. That's important because if your patient is HCV positive and if you give chemoimmunotherapy, reactivation chances are high. It is important to see that we have HCV RNA report to be there. So that was the right question to be asked. Now coming to what Dr. Anil was commenting was important, that in this setting, if you have a significant dysphagia, it is good to give local therapy. We should never forget it, and that is useful. And beyond that, systemic therapy needs to be given, and it can be chemotherapy or chemoimmunotherapy in today's time, especially if it is feasible to give the way it was feasible to do it in these patients. And the benefit is, one, to improve the quality of life of these patients, and increasing the life of these patients by giving chemotherapy, and adding immunotherapy further increases the life of these patients and also prolongs the improvement in quality of life of these patients. One of the important aspects remains that when we give this palliative systemic therapy, one has to be careful about the side effects and the impact on quality of life, especially when we're giving only chemotherapy. It may be also useful when we add immunotherapy, but in that context, we need to remember that if we do that, then you do have a small but significant chance of 1/4 of the patient having a prolonged or long-term survival, which can survive beyond 3 years or 4 years, which we have not seen in the past. Cost is a significant issue, and that remains, and that goes without saying, that needs to be discussed, and that needs to be explained to the patient and take them in confidence before planning these treatment. So that will be the first line treatment, planning in these patients. Apart from that, early palliative care as a part of the management should remain for this patient, where they need to be discussed regarding all aspects of palliation for the patient. The bone modifying agent was given, and again here, what we have to be careful that when we're giving these bone modifying agents, here it is primarily for osteoporosis. So again, the schedule will be a bit different, and again that has to be kept in mind when that is done. Another important aspect, two of them, which is to keep in mind, will be having a geriatric evaluation considering the patient is 77-year-old, so that every geriatric domain is evaluated and acted upon for individual patient. And apart from that, looks like it is a multiple drugs patient are taking, so it looks like there's a polypharmacy. So drug interaction will be key in whatever we plan in these patients. So 77-year-old, advanced stage disease. We have a systemic therapy for it, which increases life, improves quality of life, but we need to be careful in planning to see that we are able to deliver it safely.
Sir, there are a couple of questions in chat. Role of immunotherapy, IO monotherapy and IVO voltage and CPS more than 10. There is one question on the HCV RNA.
HCV RNA.
If you can
So
address
HCV
that.
RNA I had answered. Coming to role of single agent immunotherapy. Single agent immunotherapy has been tried, and that is primarily in second line setting, and looks like there is activity and one can consider, but chances of patient responding goes down. But there is a small chance that patient can be a long-term survivor. So that option remains. So that needs to be considered if in case the patient can't take it. Coming to CPS score of 10%. Now CPS score of 10% has come from a different study where CPS score becomes important, and especially in that study, adenocarcinoma and squamous cell carcinoma both were part of that study. But there are immunotherapy which can be used without having CPS score being done. But CPS score does help in where the chance of responses are higher. So it is good to do it, but not for every immunotherapy. It is required to be done, and not necessarily it is such a strong marker to suggest that patient will never respond. So it is useful in certain aspect, but in this situation, not necessarily we require to give all the immunotherapy.
Thank you, sir. Dr. Devyani, your comments, please.
Yeah, I guess in this case, there really isn't any indication for a surgical intervention. The only thing I can think of is for palliation of dysphagia and for feeding the patient. If intervention is not able to get an NGT across or a PEG is not feasible, then the max we can do is do a feeding jejunostomy for him, but for her. But other than that, I think we've covered most aspect of what the oncological treatment would be.
Dr. Anil, I think there is one question for you in the chat. If patient is having grade 3 dysphagia, then what will be the RT dose? 30 GY per 10 cycles or something else?
Yeah, so we usually follow for 30 grain 10 fraction for the durable relief of the dysphagia. So that would be the dose of 30 grain 10 fraction.
Any questions? Any other questions from the participants? So if there is none, I think we can go to the next case.
So the third case which we have is a locoregional recurrent esophageal cancer. It's a 73-year-old male. The presentation starts as an incidental finding in July 2021. FTG PET-CT showed mid-thoracic esophageal uptake at D6 vertebral level. There were few mediastinal lymph nodes which were low FTG EVIT with preserved fatty hilum. FTG uptake in thoracic esophagus was initially termed as (inflammatory) as compared to previous PET-CT dated January 7th, 2020. Scan findings are largely unchanged. There was an EGD done on July 5th, 2021, which showed a mid-esophageal lesion, and it was subsequently biopsied, which showed squamous cell carcinoma of grade 2. It was staged as T1N1M0, stage 1. Patient went ahead with curative definitive upfront concurrent CTRT with paclitaxel and carboplatin. The dosage of radiation was 54 GY in 30 fractions. And the treatment started in July 2021 and was completed in August 2021. FTG PET-CT post-treatment showed no evidence of malignancy. Post the treatment, patient was on regular follow-up from January 2022 to September 2023. Second presentation started with a complaint of dysphonia in October 2023. FTG PET-CT showed a 2.9 into 1.3 centimeter left tracheoesophageal groove lymph node, SUV of 8.7, multiple bilateral upper paratracheal lymph node, largest right upper paratracheal lymph node of SUV 6.2 was noted. Right lower paratracheal subcarinal prevascular lymph node were also noted. As compared to previous PET-CT dated May 30th, 2023, Few mediastinal lymph nodes show increase in size and metabolic activity. An FNAC was done from left upper paratracheal lymph node, which showed metastatic squamous cell carcinoma. And a FNAC was done from left hilar lymph node, which showed no evidence of malignancy. PDL1 was negative. PDL1 should be positive. Okay, so ECOG score is of 1. Patient is able to manage daily activities without assistance. Symptoms include hoarseness, and patient is planned for radiation to lymph nodes, followed by maintenance immunotherapy if required. Yeah, I'll pass the discussion over to the panel members. Thank you.
Can you go back to the history or the first radiation findings? First one. It was completed in April 2021, I guess. July 2021. And mid-thoracic esophagus. Is the primary radiation, the first radiation.
Yeah, that's here, August 21.
August 21. And what?
54 gray.
So where were the location of the growth? In the mid-thoracic esophagus, if I remember, D6 vertebral level.
Yeah.
So I would be, if you ask me about the opinion for this particular patient after a DF of approximately 2 or 1.5 to 2 years, I would be slightly reluctant to go ahead with the radiation therapy, given the fact that we have attempted or we have given a dose of 54 grain 30 fraction to the same area, more or less the same area. I need to see the radiotherapy plan, but given the area, the D6 so vertebral level, I would assume that the mediastinal lymph node would have received a considerable dose of radiation therapy. So my sequence of treatment will be slightly different as compared to what have been offered here or what have been suggested to do here. I would take an opinion of both, Dr. Kumar sir as well as Dr. Devyani, to see the role of the surgical salvage. The first thing, if by any chance the surgery is not being contemplated, I would ask Dr. Kumar sir to give some form of the systemic therapy so that we buy the time and we see the biology of the disease, and then maybe later we can consolidate with the radiation therapy if the biology is good. Otherwise, I would be slightly hesitant to offer the re-irradiation therapy in a time frame of less than 2 years. What is your opinion, Dr. Devyani, sir?
Hi, Anil. Actually, seeing this case, I think we missed the bus the first time around. It was a T1N1 disease to begin with.
I know.
In a 73-year-old. So if this patient had to come to me, I'd rather have this patient come to me the first time around.
First time, yeah.
Where surgery would have been the best treatment for this patient. But given this circumstance now, he's come back with mediastinal nodes also causing hoarseness of voice. So that means, and the size of the node is also pretty big. It's around 3 centimeters. I don't think this disease is behaving very well from the nodal metastasis point of view. So I would be very, very hesitant to offer surgery at this point. And I understand your concern about re-radiating after such a big dose in the same area. So even I think my referral would be to Dr. Kumar Prabhash to do the needful and buy some time for both of us, I think.
So, I agree with you. Disease coming and where we have more than one lymph node, being positive, and there are fairly large node, and and especially recurrent tumor in esophageal cancer primarily turns out to be systemic disease. So it is good to give systemic therapy, and it will be one of them. Either chemotherapy or chemotherapy plus immunotherapy. That will be the initial choice. And yes, one should explore local treatment if the disease in subsequently behaves well because of the treatment being given, and if there's some good response, and then we do have some residual disease and we have a prolonged control of the disease, then one should consider exploring the local treatment, and one of the local treatment can come into the play subsequently. But upfront in this situation, it will be better to expose the patient to systemic therapy. And preferably, if again, logistics and contraindications are not there, then chemotherapy plus immunotherapy. Don't forget, as I said earlier, we should always evaluate geriatric evaluation should be done. Be careful about the drugs the patient takes, and early palliative care to be included in the treatment plan.
Questions from the participants? Okay, I think there are no questions. So now my request to our panel members is to speak few words about the recent concepts and recent developments in the management of esophageal cancers in the respective fields of medical, surgical, and radiation oncology. And then we will go for a take-home message and then wrap it up. So Dr. Kumar, Professor.
So esophageal cancer, especially squamous cell cancer, which we discussed today, there has been very slow development overall, and but at least in recent past there has been some good development. One of them is the cross trial, which you keep hearing. That has been a very good development, and that you add chemotherapy to radiotherapy to have and surgery as a part of treatment, and the outcome becomes very good. In fact, as compared to what we used to treat in our time when I was a student. Subsequently, there has been some development in neoadjuvant chemotherapy, where rather than using 2 drugs, 3 drugs has been there, which is again important, in this setting, because that opens another avenue for us, especially because our patients giving chemoradiation as a neoadjuvant setting has, you have almost half the patient who can't take it. So that part of development, again becomes useful in this setting. Third has been that after giving, this neoadjuvant therapy and surgery, the patients who didn't have a complete response, and this word we have heard again and again, and that's because they do very well. The other patients, they don't do well. And in fact, majority of the other patients who don't do well, they do come back fast within a year or year and a half. And there has been a development of immunotherapy in adjuvant setting, and it looks that controls the disease well. So that has been another good development in this setting. In palliative setting, we had our own study which established that palliative setting, if you give chemotherapy, it adds life to the patient. So that is important. And now there has been multiple data coming out that if you add immunotherapy to chemotherapy, that adds life to the patient. And then in a small proportion of patient, you can have a prolonged survival, which was not the case some time back. And I can see Dr. Devyani, she will be talking about oligometastatic disease. So that I will leave it to Dr. Devyani to talk about. So that is all from my side as far as systemic therapy is concerned. Thank you.
Thank you, sir. Dr. Devyani, over to you, ma'am.
Hi, so I will stick to the advances as far as surgery is concerned. Dr. Kumar has laid out the recent advances in the systemic therapy point of view. And I think it's exciting times for esophageal surgery. It is a very demanding procedure for not only the surgeon, but mainly the patient, because it completely throws his or her physiology into a disarray. The patient, right from learning how to swallow all over again, the patient has to get used to a smaller stomach, a new tube, and the physiological implications of this surgery remain for a long, long time. But having said that, we in the recent times, with the minimally invasive surgery coming in a big way, like whether you do it video-assisted thoracoscopic surgery or robotic surgery, the outcomes have improved greatly. The second thing is the recent trial called the ICANN trial shed some light on whether a total esophagectomy is better or an Ivor-Lewis procedure is better. It was a randomized controlled trial, and interestingly, it showed that the outcomes, so margins is not, I mean, of course, you have to choose a surgery where you get negative margins. But if negative margins are possible with both these types of surgeries, then the functional outcomes of an Ivor-Lewis procedure have found to be better, because the oropharyngeal dysphagia or the hoarseness which is possible with a transthoracic esophagectomy are completely eliminated when an Ivor-Lewis comes into play. So that is again recent advance as far as this is concerned. Initially, there were some concerns that while we do an Ivor-Lewis procedure, The leaks are generally in the mediastinum and are worse in terms of patient outcomes. But this trial showed that if a leak occurs, whether it is in the TT or an Ivor Lewis, it really doesn't matter. It is managed the same way, and the severity is also pretty much the same. And yeah, I think, and the third thing that has come up in a big way is ERAS, like it has come up in all other major oncological surgical procedures. It's the same in esophagus. We take minimally invasive surgery, good pain control, and early mobilization of the patient, put as few tubes as possible, get them out quickly. And if we follow all that, we can actually send the patient post esophagectomy home, eating soft diet by day 8 or day 9, which is what we see in our center as well. So that's the recent advances as far as surgery is concerned.
Dr. Anil, your
Yeah,
views on this?
so very nicely laid out by both Dr. Kumar and Dr. Devyani. As we all know that esophagus is a trimodality treatment, mainly is squamous cell carcinoma. So we do require the help of nutritional group of people, and for the rehabilitation and the pre-rehabilitation for the esophageal squamous cell carcinoma as well as the adenocarcinoma. As far as the radiation therapy is concerned, there have been recent advances in terms of the doses of radiation therapy. We were giving a dose of 60 gray for the unresectable esophageal squamous cell carcinoma, but there has been recent evidence to say that the 50 gray is good enough for the esophageal squamous cell carcinoma. However, there are still certain criticism, or there are certain argument that esophageal squamous cell carcinoma in the West will differ differently, will behave differently as compared to the eastern population. So still some of us are still going ahead with the 60 gray of radiation therapy with a good local control and overall survival. However, we need to understand that the toxicity of the chemo radiation therapy is very morbid, especially the stricture rate, especially in the upper one third and the cervical esophagus, and as well as the lower third esophagus. If as you know that the cross trial gives you a 10-year overall survival of approximately 30 to 35%, and we need to look at our toxicity data for this long-term survival patient. And there comes the role of the proton radiation therapy, because the proton radiation therapy will have a lesser side effect as compared to what we generally use in case of photon radiation therapy. But given the fact that proton radiation therapy is not widely available and has a huge cost associated with it, we need to select our patient and cannot be done for each and every group of patient for each and every site of the disease. So proton radiation therapy is good to reduce the toxicity, but we need to select our patient population very, very selectively so that we do justice to the patient for the treatment, as well as the cost needs to be borne in the mind, so that we do not do the financial toxicity as far as the patients are concerned. So the routine use of IMRT has really helped us in treating more and more number of patients with a radical intent, as well as to reduce the toxicity, especially of the lung, as well as of the spinal cord, and of the esophagus also. So these are more or less the major chunks of the radiation therapy. And if we do get some evidence to treat esophageal squamous cell carcinoma with with the proton therapy, I hope that this will improve further in reducing the incidence of toxicity, especially grade 3 toxicities. That's
Thank
from
you,
my
sir.
side.
Thank you, sir. And if there are any other questions from the participant, I think you can unmute and ask your question. Thank you. Now I request Dr. Kumar Prabhas to give any message to the participant as a take-home message for this particular event. We have tried our best to see that we cover as much as possible in the esophageal cancer, but there are few points that would have been missed out in these cases. So if you can just give an overview of that and as a take-home message, I think that would be good, sir.
So as far as this interaction is concerned, is good. It was online, so it is easy and short period. So that is again something, it is feasible. So and it allows a whole lot of people to able to interact with each other. So that is really nice initiative. Coming to disease part of it, esophageal cancer, the take-home message always remains that it is very important to talk to your colleagues, and that's what we do it here. We always talk to each other to find out the best treatment possible for our patient. And if you do that, there is a chance that most of the time we won't err. We do err because we are human, but having said that, interacting with our colleagues are important. So I request people talk to each other. You will find that you have a good solution for your patients.
Thank you, sir. Dr. Anil Dibdewal, your message, please.
The same thing I will emphasize is that it's a multidisciplinary management. You need to speak and you need to involve all the other specialties. Don't feel hesitant to ask the questions. If you have any doubt, don't feel sorry that we don't know, or we might be so we might look bad or silly in asking question. Do ask question, even if you don't know. There are people who can help you, and there are people who will give a proper suggestion to how best we can benefit our patient, and we should be all inclusive.
Dr. Devyani Yogi, your message, please.
Yeah, I think we've covered most of everything, but one thing I would like to add that esophageal surgery, like I've said before, is very, very demanding. So we should rope in all the help we can get in terms of if we have a speech and swallow therapist in and around our hospital, a physiotherapist, an occupational therapist, and a nutritionist, most importantly. I think in esophageal surgery or esophageal treatment, these branches also play almost an equally important role as the primary treating oncologist, because nothing can be done really if the patient's nutritional condition deteriorates. So I think that is something that we need to keep in mind while we are dealing with esophageal cancer.
Thank you, ma'am. I thank all the panel members for sparing their valuable time and sharing your knowledge and experience with all of us. And I thank the participant for actively participating in the discussion and sparing your time. Now, we would close this session. I have one request for all the participants. After this webinar, once you are exiting, you will get a feedback form wherein you can suggest any topics that you would like to hear from us in coming days, and also your suggestion on improving this webinar to make it more useful and more interactive and more helpful to all of you. So please do provide your feedback. And also, if there are any questions which you couldn't ask during this session, you can please ask it in that feedback form, or you can reach out to me by email so that we can resolve those queries with the help of our experts. Thanks, everyone, and have a good day, please. Thank you.
Thank you. Thank you so much for having us here.
Thank you, ma'am.